Hello, everyone, and welcome to this webinar with the Danish Sound Cluster. My name is Pedro, and I'm the host of this event, but Kira will be the moderator. So I just want to say welcome to this one, and also to say that this will be recorded, so you can also come back to it if you like. It will be available in the website later. So I don't have much to say right now, and I'll give the stage to Kira. So welcome, everybody.
Thank you, Pedro, and welcome, everybody. I'll just say a few words about the program today. And we will also maybe see it on the screen. First, today, we'll just see it here. Oh, it went away again. It will be back. But Peter and I will begin by introducing the topic of music interventions in healthcare. This will be followed by two examples of how music is used in healthcare by Danish companies. First, with a focus on cochlear implant users by Kathleen Faulkner, and then with a focus on music in tinnitus rehabilitation by Jakob Nielsen. And I'll just say a few words about the speakers also. So you're very fortunate today to have a great group of people. First, we'll hear Peter Wust, who is a professor at Aarhus University and the Royal Academy of Music. And he has the great combination of being an excellent scientist and also excellent musician, which provides a great fundament for the research that he's doing. And he's done an amazing job of building up this field of music neuroscience in Denmark. And this has resulted in the foundation of the Danish National Research Foundation Center of Music in the Brain, at which we're currently working. And then it's also my great pleasure to present Kathleen Faulkner, who's PhD and has been working with individuals with hearing loss for more than 20 years. She's been working both as a clinical audiologist and also as a scientist, both in academia and industry research, and with a particular focus on cochlear implant users to understand the great variability in both outcome and benefit for patients who use cochlear implants. Then we also have Jakob Nielsen, who has the combination of multimedia technology and musicology as a background. And he's been working many years at VDEX, which is now part of WS Audiology. And he's been working on developing new algorithms for hearing aids. And today he'll tell us about his work on music solutions for tinnitus treatment and his work with also random generated music and the complex interaction of both hearing aid technology, music, and human psychology. And finally, I will also be saying something. I'm an assistant professor at Center for Music in the Brain at Aarhus University. I have a background in both psychology and music therapy. And my research has been focusing on music interventions in healthcare and clinical applications of music, with a particular interest in sleep and sleep disorders. Yes, so I'm very happy to be presenting this program today with all the great people. So with this, I just want to give the word to Peter, who will begin this introduction.
Thank you very much, Kira. We are, of course, here today because we have just released this small book, and the idea about this book is that we wanted to give an overview of the different clinical applications, the things you can use music for in healthcare. And I would just say that this is basically, it's not a new book, it's an update of the book that we wrote in 2014, but we felt that there were so many things that has come about since then, and I'll just show that in just a little while. but just to say that we believe that it's important to have something that is readable but still scientifically sound. And especially Kira has done an excellent job of updating what we had here. So it's actually a much fuller picture of what we know now. Anyway, I would like to say, of course, that we are, Kira and myself, we are from the Center for Music in the Brain. We are at the moment a little bit more than 30 researchers. And basically, the Center for Music in the Brain is a basic research center. But so we are interested in understanding what happens to the brain when we listen to music, when we play music, when we use music in different settings. But this basic research, of course, is only interesting if it has an application. And one of the applications is, of course, in healthcare. And that's why we have, over the years, worked with a lot of different areas. We have done pain research. Music can relieve pain. We have been interested in insomnia, which is Kira's area, but also Parkinson's disease, which I will talk a little bit more about today, and different other areas that we are very interested in. But just to say why we feel that this is necessary. The thing is that there have been so many publications on music and clinical applications over the last year. And if you just look at this, when we wrote the last book, or white paper as it is called, in 2014, we were around here. But then if you just, if you know a little bit of mathematics, you can see that at least twice the amount of papers have come out since then. And that's just if you search for music intervention in the database Scopus. So why all these publications? So you can ask, why actually use music in healthcare? The thing is that from our basic research, we know that music does a lot of different things to the brain. It can change the way we feel. It can change the way we listen to the world. It can change our motor output. It can change a lot of different things. But why use this in healthcare? And see, the thing is that music is, first of all, it's non-invasive. It's without known side effects, so as far as we know, and it's very easy to administer. Often you can just play what, I don't know what you play today, but I would say a CD or a tape to patients. But another thing that is also very important is that it's super motivating. So for many people, for instance, if we take pain relief, we know that music will actually relieve pain. Another thing that we know relieves pain is when you do calculations in your head, you're distracted by doing something. But it is very difficult for people to actually want to do calculations in their head if they want to relieve pain. Listening to music is much easier and much more motivating. So and also it's very abstract. So it's something that you don't get into a lot of fights about. That's not completely true. I fought a lot with my father about music, but that was a different thing. But in general, it's very abstract. So it's not something that necessarily gives you some specific connotation to it, like you would do if you, for instance, were listening to a story or something. And then it's universal. It's all around the world. Everybody listens to music. So that's why we have, as I said, done this white paper, this small book, where we have looked at all these things. And if you look through this book, you can see that there is an introduction, of course, and we start out with talking about how does music work, and what are the building blocks of music? What is it in the music that works? And then, of course, how does it affect our brains, to get an idea of why is it that we can use music, and which kind of features about music should we use in different clinical settings. So we are talking about how can music be used in healthcare more specifically, and we are looking at somatic disorders, psychiatric disorders, and well-being. And Kira will take care of the last things just in a minute, but I'll start out a little bit by talking about how music actually works. And one thing that you will find in this white paper is you will find this table where we have all the different disorders, but also an idea about what are the brain mechanisms behind these different applications of music. Just as an example, if you think about operations, we know that music has been used very successfully before and especially after operations to sort of calm people down and make them think they're waking up from an operation and they're thinking, oh, where am I? And then they listen to music and they say, oh, that's a nice environment. I know what this is. And of course, in that respect, you want to use the emotional aspects of music, for instance, but maybe not, you don't want any motor output. So you don't want music with a lot of rhythm in. So for all the different things that music can do to your brain, we have tried to look at the mechanisms behind it also, because understanding the mechanisms is crucial for understanding how you should be using music, or if you should use music at all, because in many instances you might not want to use music. So this is a very important thing, and what you can see in this white paper is also that we have graded the different the knowledge that we have about different the different areas, whether it's a level 1, 2, or 3 according to the Oxford guidance. The guidelines for how well the evidence is actually. So, and Kira will talk a little bit more specifically about this, but this is important to understand how sure are we that this is actually does work. So you can find all these things in the book. But if we then go to what is one of our main purposes about this white paper, that is that we also want to highlight that we know a lot about how music actually works and what it does to the brain. And this can be used in order to find new applications of music and optimize the applications that we already know. And if you want to know more about this, you can read my latest paper in Nature Reviews Neuroscience, which is a complete overview of the field, what we know now, and it tells us a lot about what we know about music and its relationship to the brain. And it has it's based on a theory, which of course is more than a theory because it's very well substantiated, but it's called predictive coding of the brain. And I'll try to explain to you why this is super important. So if we take a very well-known application of music, and that is that if you have patients with Parkinson's disease, we know that music can help them to move better. Actually, only a metronome can make them move better. You know, in Parkinson's disease, if you take patients off their medications, they will often freeze. That means that they won't be able to continue their movements. And what you can do in order to make them move is simply do it like this. So patients suffering from Parkinson's disease, they will actually move better just to metronome. I have a short video you can see here. When the metronome starts, you can see how this patient actually starts moving much better. So why is that? That's actually a mystery. But in principle, it has to do with what I was talking about before, which is the theory of predictive coding. The idea about predictive coding is that what the brain, when we are trying to make sense of the world we are walking around, we are trying to make sense of what is happening. What the brain is doing all the time, it's trying to predict the future. And if everything that comes to the mind just is in accordance with this model we have for predicting the future, if our prediction is correct, given the input to our senses, nothing happens in the brain. So it's only when something that is not what we would predict is when we're experiencing that, we get an experience, and we might think, okay, what is happening? Should I change the model about my world? So this is something that art deals with all the time. Think about this. This is a painting from Aarhus, in the art museum in Aarhus. You can see that what you're looking at in this, I don't know whether it's a beautiful image, and I know nowadays people say they're looking at the Ukrainian flag, but in principle, what you're looking at is these two annoying bumps on this, what is supposed to be a straight line. And that's because when our gaze comes from here, it sees that, okay, this is just a straight line, it's fine. Oh, what happened? So no matter how many times you look at this image, these bumps will annoy or create some kind of noise that your brain is not able to get rid of. And this is the whole thing about the art. It makes noise that the brain cannot get rid of. Same thing in more fantastic images like this, for instance. I took this with my own mobile phone when I was in Italy, looking at this fantastic painting by Leonardo da Vinci in Milano. And what is here, you have also a very nice line here, but there's something that is really annoying to the eye, and this is this finger. And I just want to say it's this finger he's using. So anyway, just to tell you that this is what art will do. And how does music do that? Well, what music does is basically that, for instance, if you have rhythm, talking about rhythm just specifically, then what your brain will have as a straight line is, for instance, 4/4 to the beat. So 1, 2, 3, 4, 1, 2, 3, 4. So this is what you experience as the straight line. This is what your prediction would be. But then in all kinds of rhythms, you will have something that actually will go against that, and we call that syncopation. Here you can see we have this syncopation. So this rhythm goes like this: do 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 ga ga ga. And so, when your brain encounters this, it perceives something that doesn't go according to its predictive model, then it will actually typically try to correct it by moving. So that's why we bob our heads in time with the music. The 4/4 we bob our heads to, so that we can sort of emphasize that this is not the correct model. And over time, you'll experience emotion and learning. So very importantly, what we have found out and become pretty famous for doing is that there is an inverted U shape. The more syncopation, the more prediction error you have, the more you like the rhythms, the more you want to move to them, to correct them. You actually also get pleasure for that until a certain point of time. Then you cannot figure out what's happening, and then you don't like them anymore. So if you go from very simple rhythms to very complex rhythms like this, then people will start moving more and more, and then at a certain point of time they will stop moving. And when you do that and look at the brain, then you can see areas for motion, but also areas for pleasure here in the frontal lobe and deep down in the brain, lighting up. So emotion and motion you get that from this very simple principle of predictive coding and prediction error. So why is this important for our clinical applications? This is important because when you have patients and you want them to move, you first of all have to understand what is it that makes them move. And here, this is a study that was done by Victor Pandu from our center. And what you can see here on the right side, or the left side, you can see how normal people react to more and more, increasing levels of rhythmic complexity. If you go from left to right, you have more and more complex rhythms. And you can see that it's the medium complex rhythms that people who are not ill with Parkinson's disease will move mostly to. So something like that. Whereas if you look at the Parkinson patients, they will like the rhythms that go like this. So here you can already see what you need to take into account when you want to have dance classes for Parkinson patients, for instance. But more than that, you can also see there's quite an individual variation that you have to take into account. So this is the most important thing. And I could have shown you also that what happens in the brain is that when you have, for people without Parkinson, for the medium syncopated rhythms, you see the connection between what they're hearing and the premotor cortices, especially the supplementary motor area. Whereas this connection is only present in Parkinson patients for the lower rated, so for the low syncopations. So if you want to engage the motor system, you can simply, we have shown that this is something that will be done differently in these patients and in people without Parkinson. And so that's just the principle, and that's the idea behind this white paper. And now Kira will take you on a journey through the different somatic psychiatric disorders and well-being, and be more specific about this.
Yes, thank you very much, Peter. I will just we need to change the screens. But it's true, I'll continue from here.
Peter, you have to unshare first, right?
Yeah. Great. So let me see here. Do you see my screen?
Yes, all good.
Yes, great. So as Peter introduced, part of the background of this webinar is the white paper that we're doing on music interventions in healthcare. And as Peter mentioned, we have a very comprehensive introduction to understanding the basic mechanisms of music and music in the brain. And this is followed by a section overviewing the clinical applications for lots of different disorders. And as Peter mentioned, one new thing that we've added to this update is a quite thorough assessment of the level of evidence for each topic. And here we've used the outline by the Oxford Centre for Evidence-Based Medicine, because we wanted a standardized way of assessing this. This is so the level of evidence for each topic is estimated or is labeled out here in the right column. And we used the Oxford Centre for Evidence-Based Medicine because we wanted a standardized approach where the assessment that we did was comparable to assessment in other fields. And because they have developed a very great tool for doing this. So for different research questions, they've made a very specific description or characteristics of what it takes to be categorized the evidence at a given level. And in this context, the question that we are interested in is the treatment benefits. So does the intervention help? So in this case, does music help for the different conditions? And for this question, the level 1 evidence is considered when there is a systematic review available, a systematic review of randomized controlled trials or N of 1 trials. That's considered level 1 evidence, meaning that we can trust this evidence to a degree where we don't suspect new studies to alter the results. Level 2 evidence is when there exist randomized controlled trials or observational studies with a dramatic effect. Level 3 evidence is non-randomized controlled trials or follow-up studies, etc. And here in the white paper, we decided to only include topics where there was level 1, 2, or 3 evidence available, because it's such a broad field, so we needed to kind of make a boundary. And since I suspect that the background of the people at this webinar has a very broad background, so I'll just mention briefly that randomized controlled trials is like the gold standard of research designs when looking at the effect of a given intervention. So in a randomized controlled trial, you have a group of patients or participants, then you randomly allocate these to either the treatment group or the control group, and you do a follow-up and compare the results. So here, of course, the idea is that the intervention is the only systematic difference between these groups, because all other relevant variables that could be age, symptom severity, gender, whatever, that is randomly distributed among the groups. So the treatment or the intervention is the only systematic difference. Systematic reviews is when synthesizing the results of randomized controlled trials using a quite strict or systematic procedure for both identifying all available studies and evaluating them and synthesizing the results both qualitatively in a narrative fashion and also quantitatively in a meta-analysis. So this is the type of evidence that we've been searching for this white paper. And as you see here, actually, the field has reached a stage now where there is level 1 evidence available for very many of the topics. So this means that there have been now conducted so many randomized controlled trials in many of these fields that they can actually be synthesized in a systematic review. So that's indeed very encouraging. In addition to this new feature, we've also added a couple of new topics. As I said, the criteria was that there had to be level 1, 2, or 3 evidence available. And actually a number of new fields compared to the original version of the white paper have emerged. So one of these is the use of music for COPD, where especially my colleague Mette Korsgaard has done a great work in her PhD project at the Center for Music in the Brain on singing training compared to standard treatment in COPD rehabilitation with very great results. Another field is multiple sclerosis, which has been investigated in a similar fashion to a rehabilitation of Parkinson patients, so also rhythmic stimulation for instance, gait improvement in patients with multiple sclerosis. Dental procedures is also a new field that we've added, because actually quite a lot of studies have been developed or conducted in this field, looking especially at anxiety reduction and pain reduction with dental procedures. And then we also added pain management as a separate topic, because as Peter said, this is a field that's been very well investigated in the last 10 years. So the knowledge has really increased, and we found it relevant to convey this. Within the headline of psychiatric disorders, we've added ADHD. This is level 3 evidence, so there's still a limited amount of evidence available, but still Also, since it's often children that are affected or that may benefit from the music, we found it relevant to include. And finally, within the well-being domain, we added a topic of pregnancy and birth, because also a lot of research has been done in this field, and I'll present briefly. So, as Peter mentioned, we've ordered all these topics in somatic disorders, psychiatric disorders, and well-being. And since there's a limited amount of time available, I can't go through all of it. I can only encourage you to read the white paper. I'll give you links to where you can find it for free towards the end. So I'll just give you an example from each of these categories. So for the somatic disorders, one of the topics that's been really widely investigated is the use of music for medical operation and other types of invasive medical procedures. And it's really encouraging to see how many studies are now available. We found systematic review including 92 randomized control trials. So in this systematic review, more than 7,000 patients were included from all these 92 trials. So that's a lot of participants and really gives a substantial knowledge about this effect. And the interesting thing is also that it enables us to see, look into some details and interesting questions with regard to the intervention. So one result was that they found a clear reduction in anxiety with the use of music. Could also you look at different studies using preoperative music, that is music before the operation. For anxiety, you see that's very effective. Also music during the operations or after the operations. And they could also look at whether the music was chosen by patient, investigator, or if the patients brought their own music. So these type of questions can increasingly be shed light on. So that's very interesting to me, at least. I hope you find it interesting too. Similarly, they found a lot of outcomes, or a lot of studies measuring pain and looking at pain reductions, where you also see a clear reduction of pain in the groups listening to music. And here, interestingly, also we see that maybe the use of music before the operation is less effective for the pain, but during, and particularly after the intervention, is the most effective, which of course makes sense. So this large pool of studies enables us to kind of disentangle a bit more about the music interventions and how this effect is conveyed. So for the psychiatric disorders, I'll just give you an example of insomnia, which I've been working with quite a lot. And just here in August, we published a large new systematic review, including 13 trials. And 10 of these studies could be included in the meta-analysis. And interestingly, we see a clear reduction of sleep problems in participants listening to music at bedtime compared to control participants with no music. So this is what's called forest plots. This is the result of this meta-analysis, and we see here a reduction in sleep problems in the music group compared to the control group. In this systematic review, we also very systematically evaluated the quality of the studies for different types of bias that might be a result of the design or the procedures of each individual study. And a lot of progress has been made here. Of course, one thing that you see very clearly is that there's a high risk of performance bias. So this relates to the fact that with music interventions, it's not very easy to blind participants to whether they listen to music or not. So this is kind of a thing that we have to live with for music interventions. But in the other domains, most of the studies actually are at low risk of bias, which kind of increases, of course, the validity and how well we can trust these results. Yes, so I'll continue with an example from the well-being domain. As I said, a new topic that we included was pregnancy and birth, and there were both systematic reviews on the use of music during pregnancy, where the results showed a clear reduction of anxiety during pregnancy, even though no result on stress, no reduction of stress was related or was found. And other studies and other systematic reviews focus on women giving birth, and these are the results from a systematic review on women during labor. So this is the outcome of anxiety. We see a clear anxiety reduction across these studies of women listening to music while giving birth or during labor. Interestingly, many studies, or a number of studies, have also measured different types of physiological outcomes. And here, for instance, 4 have measured heart rate and also saw a related reduction in heart rate during the process of giving birth in mothers, which of course is super important because both anxiety and heart rate are related to a positive process of giving birth. And at Center for Music in the Brain, we've also been very interested in how music may benefit pregnant women. And we're actually right now conducting a randomized control trial with pregnant women listening to music at bedtime to see if this may improve pregnancy-related insomnia, which is a huge problem. And not only to the pregnant woman, but it's also been related to poor caregiving abilities after birth with persistent insomnia during pregnancy. So I'm very excited to see the results shortly when this project or when the data collection finishes. Yes, so with these examples, I just want to finish with a number of considerations when considering using music interventions in healthcare. One thing, of course, as I've highlighted here, is to look at the quality of the evidence. So what is the evidence base for actually suggesting a music intervention in a healthcare setting? That is one thing to consider. Another thing to consider is, of course, the technical aspects of implementing music interventions in a healthcare setting, because often, whether it be it at hospitals or nursing homes or whatever, there is a caregiving aspect, and it may be people with severe disorders. So, of course, we need to ensure that there are technical solutions for providing the music which do not disturb or interfere with the medical treatment. Another very important thing to consider is, of course, the choice of music. And here it varies a bit from topic to topic. In some areas, it seems to be very important, or there seems to be a larger effect when people choose their own music or bring familiar music that they listen to, for instance, with analgesic effects. This seems to be an important factor, using self-chosen music. Whereas in other domains, such as sleep and stress reduction, it at least as the evidence look now, it's a less important factor. But this is definitely something to discuss, and I think most studies show a good success with giving participants a choice, for instance, among predefined playlists, as a kind of way of balance, maybe some objective characteristics of the music, and still the individual preferences of each person. And finally, of course, there's the feasibility that when working with people in a healthcare setting, there are a number of procedures that we need to make sure both that the music does not disturb, and also that the music intervention needs to be built into this flow in a natural way. So who will administer the music? Is the patient able to do so themselves, or should it be nurses? Or all these things need to be thought through very carefully when implementing music in healthcare settings. So with this, I just want to tell you that the white paper is available at the Music in the Brain webpage and also the Danish Sound Cluster webpage, and these are the links. So I hope that you'll be able to find it and enjoy looking into it. So with this, I just want to thank all the partners involved in this project, and then give the word to Katie, who will talk more about cochlear implants. And maybe I didn't say so in the beginning, but our idea was to take questions towards the end, because then we can have more of a discussion about the topics that may be raised. And you can write questions in the Q&A. I think Pedro also wrote so. You can write it along the way, and then we'll take it in the end.
Caitlin, can you share the screen, please? Thanks for the great presentation, Kira.
Okay, now I think, can you see my screen okay? Okay, so I'm going to talk a little bit about the music interventions in healthcare related to music and cochlear implants. And I just want to thank the Danish Sound Cluster and Kira and Peter for allowing us. I worked with Mariana Vazzi, who's a research engineer with me at Oticon Medical, to being able to contribute to this white paper. It was a really nice experience. So I'll start maybe with a little more what we're going to talk about for my section is what is a cochlear implant. And I know some of you may be familiar with the technology and maybe some aren't, and a little bit about how it works. And then what the challenges are that cochlear implant users experience when they are listening to music. And then also talk a bit about some of the different ways that music can be used as an intervention with a CI user, because after we've been talking about all these interventions with them, some of the issues with the cochlear implant user is just being able to perceive the music. So some of these interventions are going to be a little different when you have somebody with hearing impairment or someone who uses a cochlear implant. So what is a cochlear implant? So it's a surgically implanted device. It's for children and adults that have severe to profound permanent hearing loss. And typically for those who no longer benefit from having hearing aids. Now, some people use a hearing aid on the opposite ear or have a little bit of residual hearing in the ear while they get a cochlear implant. So that also depends on, the hearing aid may actually provide some benefit in music if they have that. And so how does the cochlear implant actually work? So cochlear implants work differently than a hearing aid in that it actually doesn't just amplify sounds. It takes the sounds from the environment and it delivers that sound directly to the auditory nerve. So what it does here is you have an external sound processor and a receiver. So there's external parts and then there's surgically implanted parts. So the external processor sits behind the ear just like a hearing aid. Here, let me see if I can turn on my pointer. Okay, so the sounds arrive to this signal sound processor. It takes the input and converts it into digital signals, which then transmits it across the skin here via this radio frequency signals to the internally implanted receiver stimulator. Then the implant converts these signals to electrical pulses that are delivered to an electrode array that's implanted directly into the patient's cochlea. So there's individual electrodes that are spaced around in these different regions meant to stimulate different areas of the cochlea in a tonotopic or frequency specific manner, and then that signal is delivered to the brain. So the CI has been considered to be the most successful neural prosthesis to date, and it does functionally restore access to sound, but it's a little different when we come to music. So this is a really nice publication if you're interested in learning more about the challenges that CI users experience in terms of how we perceive music or how they perceive music. So we can look at different aspects of music in terms of pitch, rhythm, timbre, sound quality, or loudness. So some CI users are going to be kind of within their similar to normal hearing listeners across some dimensions like rhythm, for example. It's really well represented in cochlear implant, at least at a simple level. So maybe not with multiple percussive instruments, but maybe simple rhythm. And then some of the bigger challenges are going to be with pitch and timbre. And you can see if you go to this publication, some of the very specific characteristics that are really difficult in terms of being able to detect two different pitches, being able to follow a melody, as well as timbre, which is being able to distinguish between two different instruments playing the same melody or playing, same melody. So you may be able to distinguish these sort of broadly bigger differences, but when we get into a similar type of instruments, they're going to have more difficulty. So there is some research that shows that cochlear implant users often prefer solo instruments or simple structured music, maybe pop music, and also ones that maybe if it's somebody who lost their hearing, something that they remember so that they can map it to memory, rather than complex musical arrangements that are really complicated and difficult to perceive. If you want to know how it sounds, you can Google cochlear implant music simulation to hear a little bit of a sample of what might be how it sounds different. So why is music such a challenge for cochlear implant users? So a cochlear implant is optimized for speech. It's really good at detecting speech and transmitting the redundant signals of speech. And all cochlear implant users, whether they're good users or poor users, they're going to struggle when there's speech in the presence of background noise and with music, and because they have really the same underlying issues. So there are some device limitations about the signal processing. So how the signal comes in, what happens to it, how it's compressed, how it's delivered. There's a finite number of electrodes that are spaced along this the cochlea, which are much more restricted. Electrical stimulation is also very broad, so it's very effective, but it means we can't stimulate just a single neuron. We're going to stimulate really broadly. And so the brain often has to do the work to really detect what's happening, especially in music. And there's also a lot of current spread. So like I said, it's going to be a broad stimulation, so it's going to activate a lot of broader regions. And so it's going to be difficult to detect if it's a single tone, for example. Then given that, there's also biological limitations. So people who use cochlear implants, particularly those who have long-term deafness, may actually have deprivation effects, neural health issues, even levels across the all the way different centers of the brain. They may have reduction in density of neural fibers. So it may not even be able to transmit the information similar to a normal hearing. And again, spread of current could be also on the perceptual side. So there's a lot of masking across of different electrodes. But it is really important really to understand that even if we maximize the cochlear implant from the outside in, so we make sure that those cues are represented, it is not a guarantee that each patient will be able to detect those sounds. So cochlear implant stimulates very differently. So you often need to learn how to listen for these different cues that you normally wouldn't have found to be meaningful. And the field in general has moved into we really were focused a lot on perception, like I was saying about actually getting the signals right. So music perception reflects how individuals can actually identify or discriminate different sounds or a musical feature. But the field is moving a little more into this music appraisal, how it represents their subjective experience, because we know that given all these limitations and how terrible music sounds like it sounds to them, there are people who really appreciate and really love music, regardless of how well they can perceive it or detect it. So there can be people who have incredibly poor outcomes who aren't doing well with it, but still love music. And there are people who are considered our star performers who do extremely well that are very disappointed in music. So there's often really unlinked between perception and enjoyment. So those are two really interesting things to keep in mind. So when I think of the music interventions, a little different across from what Kira was saying, right? We're talking about intervening using music as a treatment, but in this case, we're talking about how do we make sure that music is well represented, and then it could be used as a treatment, for example. I talk about how there's a peripheral side. So there might be two different ways that you would approach how do you improve music. So first would be to focus on the peripheral. I've kind of imagine splitting this in half. So we have the external part, which is the ways to improve how the signal's delivered, how the signal's encoded. And then on the other side, we're going to focus on improving the perception or the enjoyment of that music, because it may be you can improve it in one side, but unless you can actually teach someone how to hear those different cues or find value in it, it may be challenging. So these are the two approaches in the field. So a way to improve the signal delivery might be to improve the sound coding strategies. So there's lots of different ways you can stimulate with a cochlear implant, and there are ways to optimize to try to improve how music is reflected. There are other methods of different ways you can stimulate with electrical current to reduce how the overlap for the channel excitation. There's also an effort to customize music compositions. There's actually some researchers, so Walter Noguera in Germany has been doing concerts for cochlear implant users. So actually designing music that's meant to be well perceived by cochlear implant users. There's also ways we can do pre-processing in our devices. And then there may be a way to optimize the mapping. So like I said, there are patients who have long-term deafness. They may have a neural dead region. So maybe we can actually guide the right frequency to the right place and make their mappings better. So on the other side, we have focused auditory training. So really focusing on these very small distinctions of frequency to try to teach, or intensity or some other element, or top down, which is more cognitive driven. So trying to improve outcomes that way. There are group or different types of music interventions that are available to get people in a group dynamic where they're playing instruments or singing or listening to music, even creating their own pieces of music. And then there's also some multisensory approaches. So if given we have a limitation on the encoding, how can we improve music by maybe adding another multi-sensory approach, an audio-visual element or vibrotactile? So that's actually some of the research in Oticon Medical is looking at this vibrotactile interaction with music. So the benefits and the value of the music interventions and CIs are often that there have been reports in improved musical feature perception, improved music appraisal. There's been some demonstration of transfer of learning from music to speech understanding and language outcomes in children. The skills for music training are very applicable to the cognitive processing of speech. There's been benefits with psychosocial benefits, music engagement, quality of life. I mean, this is what we were talking about here. Music is engaging. Music is such an important part of people's lives that it's a really important value to try to target this so that we can use music meaningfully in people's lives. So when we look at the outcomes, we're also curious about the mechanisms. And so when we think of the mechanism of what's actually underlying these benefits, is that on the encoding side, we're going to look at improving the functionality using a signal processing technique. So optimizing it for an individual, reducing that current spread using focused stimulation, electrical stimulation strategies. There's also some newer movements in terms of machine learning, which can help to optimize or automize and use performance prediction to see if we can create better ways to fit implants for individualized, and then increasing the accuracy of the encoding. And on the mechanistic side for training, so we're really thought to reflect neuronal plasticity, restoring functional connectivity through auditory brain regions. There's a lot of theoretical models in terms of this opera hypothesis, which is very well known in the literature here, understanding kind of these overlapping central brain networks that also are for music and for language, so that there is a benefit that we could think of music training as supplementing improving speech understanding as well. And there is evidence that's coming out of music in the brain research that's shown that active engagement with music is what promotes the plastic changes versus passive engagement or just listening to music. So there are some challenges. Now, granted, this was a good experiment in really identifying the challenges where we may have a weaker outcomes in terms of the benefits for individual listeners are mixed. So there are a lot of constraints with these kinds of studies because we're talking about a highly variable clinical population. It's very difficult to have sufficient control groups, control conditions, some of the experimental approaches, and that sometimes it takes long, time-consuming longitudinal studies. So we really do have a need in the field to develop these high-quality randomized controlled clinical trials to properly evaluate the benefits. And also just to standardize the outcome measures. A lot of times in these experiments, people are using their own measures. So what's the measure of benefit? What is clinically meaningful benefit? What are the things that we're looking for in terms of the training and then the transfer of learning? So there's a lot that we need to do in the field in general. So in summary, the cochlear implant, we know that doesn't faithfully convey the detailed information for music to really be perceived accurately. There are some improvements in CI signal encoding that can make music more accessible, but we know that pitch, melody, and timbre may remain poor given the current cochlear implant designs. But however, there are positive clinical benefits for music training, from perception to psychosocial benefits, but we really do want to have some higher quality evidence to support that. And it is important to think that perceptual accuracy, so just pitch discrimination, for example, is only one dimension of music. And so some features may never be represented in the current technology, but music enjoyment, music appreciation, and engagement are really meaningful outcomes of music interventions. And as an example, so Oticon Medical, we've always wanted to really support research in cochlear implants and music. And so we've held this Music and CI Symposium. This was our third this last year, in terms of being able to provide a forum for CI music researchers to come together and really talk about science. And one of the really important things that happened in this was this CI user panel. So bringing in real CI users to offer their experience, some of them being professional musicians. And it was very interesting to see these researchers who said, you know, the CI is limited, this is only the outcomes they can get, to a professional musician who has been training constantly and can tell these, you know, differences in instruments. And so it was a really nice opportunity and unique in that no one else has these user panels that come and that really engaging them in the research. And so Kate Gefeller, who is one of the leading music and CI researchers, actually had the CI users contribute to a manuscript to put together what they were doing that really made their music engagement most important. And so there, right now, this was from the 2 years ago, and the participants that came to this last one are actually working on the manuscript now. So it's really providing insight into the real CI user experience of what they need from music. And in general, you know, with Oticon Medical is a little different these days, but we have these ongoing collaborations in terms of the research with music in the brain. So looking at this vibrotactile along with Jeremy Morozo at DTU, and then with Stefania Serafin at Aalborg University, we were working on some rehabilitation tools with her students. So in general, we have a lot of activities going with research with cochlear implants and music. So, you know, it's a very important part of what made Oticon Medical and what our goals were. And so I thank you for your time and thank you for including me.
Really good. Thank you, Kathleen. You're right. You want to take, should you talk or should I talk? Yeah, really good. Thank you so much. I guess now we can then just do the Q&A afterwards and pass the ball to Jakob.
Okay.
If you can present.
I'll try to do that. I guess this is the one. Yeah, like that. So I guess you can see my screen now.
Yes.
Okay. So first of all, thank you for. Can you hear me? Good.
Yes.
Okay. Thank you for letting me in. I'll tell you a little about how to use music in tinnitus treatment. And I've done this with the help of Sueli Caporali, who's audiologist, PhD at VS Audiology as well. Yeah. Okay. Oh, I should just do like this in order to make this work. No. Oh, that is. Okay, tinnitus. First of all, what is tinnitus? It's when you hear noises that are not caused by sounds from the outside world. And these sounds, they could be ringing, roaring, hissing, buzzing, whistling, whatever. It's something that happens inside your head, and it's very common. Actually, it's when you go and ask people, okay, what chronic conditions do they have? It turns out actually a lot of people have tinnitus. This is 13% in a Danish population. And when you look at the age of the population with tinnitus, it turns out that the older you are, the bigger the risk of having tinnitus is there. And again, with hearing loss, it also turns out the greater hearing loss you have, the greater odds for having tinnitus is there as well. So there's a connection between the hearing and the damage of the hearing when it comes to tinnitus. And I will try to look a bit more into that. So usually the most common hearing loss when in connection with tinnitus is the sensorineural hearing loss, which emerged from the cochlea. And when there's a sort of reduced signal from the cochlea to the auditory pathways, it turns out that there's an increased spontaneous activity in actually all the way up through all the way up to the auditory cortex. And a thing which is key in this is also that usually sounds that from our body and from the outside that is unimportant for us, not having any information or anything for us, is usually gated out. But that's not always the case in tinnitus, and we'll come back to that. When a tinnitus is chronic, also other parts of the brain starts being part of this, especially those related to emotion and moods. Yeah, but the thing is, there's no single origin of the tinnitus that is known to anyone, so we don't have a specific place to go to. We can't cut anything out or something. So what is then the problem, you could ask? And you can see actually from this survey, you can see that half of the ones with tinnitus doesn't have a problem. And then a lot of them with tinnitus has a problem with the ability to hear, which is again related to the hearing loss, but also concentration, ability to sleep and social life, emotional, mental health, and at the bottom, if you look at this, ability to work. So it can actually be quite a big thing to have tinnitus. So and why is this? I would like to, if you have tinnitus, it can sort of stress you up because it's quite annoying, and for some it could also be sort of fearful because of you don't know what it is, where does it come from, does it go away, will this destroy my entire life? And this stress induced by the tinnitus will actually make your brain focus even more on the tinnitus, and then the tinnitus, when it's worse, the stress is worse, and so on. And you could say the more you think about your tinnitus, the more you think about your tinnitus. So you would like to sort of get on from that path. So what do people do when they have tinnitus? What kind of treatments has been tried? And if we look at this, there's a big list here with hearing aids, music, medication, relaxation techniques, and sound generators, diets, and psychological counseling. And at the top one, we have the hearing aids and the music, which in my world is very interesting. And you can actually see that the most efficient, this is the report of the patients themselves saying, okay, what is efficient? And they actually say that using music is quite good. So, but we should not leave out all the other possibilities, even though the efficacy may not be as strong, but altogether there might be something. So when we do a treatment for tinnitus, first of all, we should know that there really ain't no cure. We don't have a cure for tinnitus. We can't make it go away totally. And so the goal of the treatment would be to habituate to the sound, meaning get used to it in such a way that it's not affecting your quality of life anymore. So what we do is to treat the reactions to tinnitus, and by that to the habituation, which is what I just as I just said. And we have this example in order to understand the habituation. If you get a new refrigerator, the sound is a bit different from the last one, and you say, "Oh, it's too loud, and I don't like this sound." But after a while, it's not that bad, and after a longer period, you actually don't even think about it anymore. So in that situation, you actually habituate to the sound. Your brain says, "Okay, this is not important to us. We'll just leave it out." If we could do the same with tinnitus, it's really that's the sort of the goal. But the tinnitus, it's different. It's inside your head. You don't know really why it's there, and you cannot turn it off. You can't go away from it. So it's another problem. So we need somehow we need some help to be able to habituate to this. And here comes the sounds in. When we use sound stimulation, it can help us reduce the contrast between the background and the tinnitus. And it can help us from distracting from the tinnitus. If there's another sound than the tinnitus, then you can sort of listen to the other sound or just think of something else. And again, the other sound would also partially mask the tinnitus. You can't mask it totally, at least for most people with tinnitus, but that's it doesn't really change anything, because when you remove the mask again, the tinnitus is still there. So if you look at the vicious guy up here and say, okay, this guy's the tinnitus. So when we do the sound stimulation, we actually add something around it, and you can see it's still there, but it's not really that scary anymore. And you're distracted. You can look at something else, and you can sort of, it's more easy to get used to it. So that's the sort of the trick. And when it comes to music, because of this emotional feeling bad and then get stressed on the tinnitus, then we need the music to be somehow relaxing. And for that, we know a slow tempo, a low pitch, and also a low intensity. And this should be related to sort of the level of the tinnitus. If it's too loud, it's sort of not really nice to put it on, at least for some people. When we do the stimulation in hearing aids, we would like this to be able to be done for a long period. So we would go for music without a lot of repetitions, though it should still be somehow predictable, and we would like some slow variations. It should not be too boring. We would also maybe combine this with some nature sound, rain sounds, wave sounds, or the waves and the rain would have a more sort of wide, high frequent content that might be better for the partial masking. But that's not always preferred. And preference in the end, I should say, okay, we should make sure this should be pleasant. At least it should never be annoying, otherwise it won't work at all. There are some things that has been tried on this, and one is our not our, but Neuromonics has made a device some years ago with has classical pieces that would be spectrally changed to fit your hearing loss, and they added some shower sound, and then in the beginning they turn up the sound in order to mask the tinnitus enough for you to get some kind of feel of control on this, and then slowly lowering the level after some or some days or weeks. They had quite good results on that, and now there's a small disclaimer, because I'm from the WSA, and you might know that we manufacture hearing aids that can do different tinnitus treatment methods, and one is the to notch out the frequencies around the tinnitus frequency. That can be somehow beneficial, and for now I will only focus on the what we call fractal music, which is random generated music, where we use tonal patterns and we add some waves and just to make a relaxing sort of ambient sound soundscape, and then we can apply amplification according to the hearing laws. And so overall, this is a way to show the ways to habituation. If on the left side we put in the music, and at the top we say, okay, the music can help you relax and reduce your stress, and by that reduce your tinnitus reaction and making it possible to habituate. Again, the music can give you some distraction away from the tinnitus, make it less annoying, and by that both reduce the stress and reduce your tinnitus reactions. Yeah, and again, the partial masking, removing the contrast, and the same story. And this down here is the more neural way of seeing things, trying to sort of, when we add sounds, we'll get sort of work on the auditory pathways, and that way also go the same way. So the end goal is the habituation. So when we do a treatment like this, first of all, we make an audiological examination, and then we measure the tinnitus severity by using questionnaires. TFI and THI are, I think, they're the most common ones to use. And then the counseling, which should not be left out, because that's sort of part of the whole thing. Saying what is tinnitus, how to cope with it, what can we expect from this, and if you really need this, cognitive behavior therapy can be added as a component in this. Then we do fit the hearing aid, just without the tones, only with the amplification. And when you're getting used to that, then we can apply the sound stimulation, and you can choose from different patterns. And by now, where we can do streaming, you can also use some of your own music, whatever. But usually we use the built-in patterns, and we tell people to use this daily when they're in quiet situations, or whenever the tinnitus is a problem. And we do follow-up sessions in order to find out, okay, what does work and what does not work, and so on. So what can we expect from this? Here's did some trials, and in this one, I'll just actually, this is what I want to show you. We have some counseling, we have the amplification, we have the fractal music, and we have some relaxation. So it's all together, all different components in one package. And when we apply this, we can actually see, here's the baseline, and the higher you go, the worse is the impact. So sorry for that. And after the first 2 months, you can see it's already, you have a great reduction in the tinnitus severity on both scales on this. Down here, you can see the individual, and you can see from this, it's not everyone it's not good for everyone. On the diagonal, if you are on the diagonal, then you won't have any effect of this. But if you are underneath the diagonal, you have some benefit. And if you're down here, your problem is gone. So we can see here, after this while, we can see for some, but not everyone, we have some really, really good results. And for some, it's poor. And there's another study here where you can see it's sort of the same tendency, and this is prolonged up to 12 months, and you can actually see it's getting quite well after this long period. And you can see the individuals. There's a single one saying, okay, this doesn't work for this guy. It's a bit poor quality, but you may be able to see this thing is telling us that the amount of the use of the hearing aid without the music is increased over time, as well as the music is, they use the music less. So the better habituation, the less you need the music, but you still like the amplification due to the good hearing. Okay, so that was the word for me. So
Thank you, Jakob. Very good.
So
I'll just put us on. I'll remove the spotlight from you, and then we can have. You can see everybody now, I guess. Perfect.
Great.
Kira,
I saw there were some questions in the Q&A,
Yes.
and I think the first one was related to measurement methods, someone asking about how these outcomes were measured. Maybe you have a comment on that, Peter.
Oh, certainly, yes. Because the question was, is it mostly questionnaires that is used for measuring all these different things? And I would say there's such a variety of measurements. And of course, questionnaires has the problem that you tend to try to accommodate the interviewer, and they're not that reliable. So if you look at, for instance, CI, as Kathleen was talking about, then you can actually use brain measurements. And brain measurements in the sense that if you, for instance, let's say you have a person with a CI and you play different notes, then there are standardized ways of looking at that with EEG, where you can simply see whether there's sort of a bump on the waveform that you get out of the EEG. And if it's there, it's a complete objective measure or it's a measure that tells you that there is actually a response to this difference between notes, for instance. For pain, for example, instead of asking people how much pain do you feel, then we use often like these what you can call them indirect measures, where you ask people you make people listen to music, you ask them to rise from a chair, walk 3 meters, go back 3 meters, and so forth. And then you measure how long time it takes you, and you know that if it's the shorter time it takes you, the less pain you feel. So all these different measures, of course, it's super important to have something that is not just how do you feel, like the football commentator or question about it. So this is, of course, a lot of what the whole field is about. When you do this, you have to try to figure out how to randomize stuff. That's a hard part. How to measure it in a way so that it's preferably an indirect measure, and how to blind it as well as possible. I think those are the key questions.
Definitely. And if I can just add, I think also one of the developments that we've seen in the field within these last 5 to 10 years is also like an increasing, I don't know the right word in English, like solidity of the outcome measurements, or not only questionnaires, but also having these more objective measures and physiological measures, or even neurophysiological measures of the outcome. So there's definitely a lot of development there. Yeah. Thank you, Peter. So there was another question, which I think maybe for you, Katie, there was one question saying, is auditory rhythm perception different in CI users?
Yes, so actually rhythm is one of the more well-preserved elements, but again, that's also simple rhythm and simple tempo. So that's actually, there's a study that is ongoing with Peter and Bjorn at Music in the Brain, really trying to understand whether, with these really simple, we know that rhythm is somehow preserved because this tempo is very well, stimulated with the implant, but how well they can actually use these complex rhythms where they might have like 2 or 3 different beats that they need to follow, or in terms of complex rhythm, there's a lot of, this study is really interesting to look at this groove perception that Peter described in CI users. So it's really novel research, but of all of the parts of music, I think rhythm would be the most well preserved.
Okay, thank you, great. There was another question if any of us have researched music for ADHD management. I maybe comment on that, saying that most of the studies that we found for the white paper were on children and kind of managing a school environment and academic achievement. So looking at whether background music could help focus and concentration in children with ADHD and seeing some benefits of that. At Center for Music in the Brain, we've also conducted a study on orchestral training. My colleague Marie-Celeste Fasano was leading this study, which was not specifically children with ADHD, but the super interesting thing was that they did find that with the orchestral training, the inhibition or of impulses or like control of inhibitory impulses was largely improved. So the ability to function in a group setting there seemed to be a transfer effect from the orchestral training to psychological what do we say, characteristics such as being better at impulse control, for instance, which makes it a very interesting field also for ADHD interventions. There was another one also on CI. What is known about residual low frequency hearing after CI operation? And if there are benefits of trying to save residual low frequency hearing for music perception?
Yeah, so that's actually an interesting topic. So even if we're not trying to like save low frequency hearing, there's been a big push for these less traumatizing, less traumatic surgeries because it generally preserves the structure intact and actually reduces the inflammation, reduces the amount of possible other deprivation effects. Or anyway, that low frequency hearing would be really beneficial. There's a lot fewer people that have this, what you referred to in the same ear, where you have electroacoustic. So you have the implant, in, and then you also hear with low frequency acoustic hearing. So that's a more rare component, but any low frequency cues that come through acoustic is going to enhance music to a greater degree. So anytime that there's any residual low frequency hearing, music is so much well represented. The CI cannot transmit this low frequency parts that are really important for timbre. So these fine structure cues that are really rich in the low frequency cues. So anytime there can be preservation of low frequency hearing, the better the music outcomes in general.
Great, thank you. Okay, then there's a tinnitus question asking about any results regarding ANC usage, and into parentheses it says improved silence instead of music. How does this work for tinnitus? Does it make it worse, or can it be beneficial?
Maybe I should try to answer that. I don't have any direct results on this, but when you use noise canceling algorithms, you can't cancel the tinnitus. So my guess is that the tinnitus would actually stand out clearer. But on the other hand, in other situations, if you are in a for a long period in a situation with a lot of sounds and noise, it can be beneficial to use this, because you normally we say you should not sort of turn out all sounds, and because that will I haven't talked about hyperacusis, but hyperacusis is when you're sort of very sensitive to sound, and if you block your ears, you can actually make your hyperacusis even worse, and there's a comorbidity between tinnitus and hyperacusis. So I don't have a short answer, but I think for some people, it could give some calm in a situation with a lot of noise. But I think in general, it's not really a good thing. But it really depends.
Thank you, Jakob.
We have
So
a follow-up question to that. Do you wanna go, Kira, and then I can see it?
Oh, do you have a follow-up question? Come along.
Yeah, but is there actually any research about any kind of correlation between tinnitus and ANC? So the reverse question, because ANC is actually not silence, right? It's a technique to cancel out the sound, so it's quite different from silence.
I don't have any knowledge on that, and if
Okay.
there's any. So, but the cancellation is actually removing by sending out sort of with the with the opposite phase, so it's sort of cancelled out. So at the eardrum, there's actually no energy in those frequencies.
Okay, thanks.
So we may have a suggestion for new studies here, since it seems that it's not so well covered yet. Okay, there's one more question here in the Q&A asking about CI. Also, are there therapy programs that post-operatively teach CI users to differentiate the typically difficult sides of music perception in music and CI, such as pitch and timbre?
So there are music training programs out there, and so this is the problem. Sometimes they're not well researched, or maybe they don't have a lot of validity to them. But it also depends on where you live. So, for example, in Denmark, adult CI participants users will actually be redirected to the what do they call it? The centers here for communication, and they have a fantastic program that they've built up, kind of independent in their own center, for helping CI users really focus on music. But that's also because that's their interest and that's their area. But in other places, like in the US, there is no standard rehabilitation for adults. Maybe there are some for kids. So there are a lot of studies and there are a lot of programs out there. But again, we're really missing some of the foundational clinical trials to evaluate it. So and also some of the companies offer, like, so for example, Advanced Phonics has their own system of it. We were working on some things with Oticon Medical, but I know MED-EL also has their own. So there are these music training programs, but again, they're not the most validated measures, but they're better than nothing, and they're more engaging. That's for sure.
Yeah, Peter.
Yeah, I would just say add to that of course Bjørn Petersen from Center for Music in the Brain has worked on this for many years. And especially successful was his study where he had children in a music program where they were doing music together. And we could show that it improved their musical skills, but it didn't transfer to language, which was basically is of course always what you wanted to do in order to convince politicians that it should be done. But definitely they were improving on a lot of different measures of musical skills. So which is very encouraging, I think.
Definitely.
Okay.
Okay, so there was another question on tinnitus and about singing. The pitch of the tinnitus, I guess this is with tonal tinnitus. Somebody saying that she has this experience. Do you know of any research on this, Jakob?
Not exactly by singing, but I think what happens when you play a tone at the same frequency as the tinnitus, you can make sort of somehow revert the tinnitus for a while. So when you stop, it's gone, and it's really great. But then it slowly comes back, and so it's a very short thing, and I guess that's what happens when you sing it as well. So but I don't know what happens if you you could also say if you concentrate on your own singing, it's also sort of a way of getting used. What is the sound and all this, getting used to it. So I know there's also people working with tinnitus that way.
So they could facilitate also a habituation process potentially.
Yeah.
Thank you. Great. So we have one final answer or question in the chat, and we're also approaching our time limit, but there's a question regarding the playing, regarding music playback, asking about any comments, mono, stereo, spatial, using speakers, headphone, etc. I might add one thing in the things that I've worked with, that, as I said, it's of course important to preserve good sound quality. If it's supposed to be a pleasant experience listening to the music, it needs to be also of sufficient quality. And then, as I said, there is a great challenge sometimes to find devices that you can implement into the specific healthcare setting, and that's of course very variable. Here we may need the final collaborator of the white paper, actually the sound focus, who are working on specific sound solutions for the hospital sector. And this is definitely a challenge, and there are projects out there. But I think there's definitely still room for more, and it's something that is super important to consider. I don't know if any of you, the rest of you, have any comments on this. Peter?
Always a comment.
That's great.
I would say that we worked some years with using live music in hospitals. Unfortunately, it didn't work. It didn't work better than just playing a CD. So you can say that I think that it's more the emotional content and or rhythmic or ability of the certain music to engage the participants that is mostly important in most of these areas. Not necessarily tinnitus, but in the other areas. So yeah,
Definitely great. Yes, so it's 1 minute past 4:30. So I think we'll finish with this.
Yeah, and I just want to say thank you very much for this. It's been very informative. Thank you for sharing your knowledge. I'm sure everybody is really happy with it. I also want to say that we will send out a follow-up email with the presentations and the link. And also there is a 1 minute survey after you close this. So if you could answer that, it would be really fantastic. So thank you, everybody. It's been a pleasure.
Thank you.
Thank you for the great work. Bye.
Bye.